So, greetings everyone. My name is Jean-Pierre Kikens from covexit.com, and I'm very pleased to welcome today for an interview Marc Girardot from France. So, welcome, Marc.
Hi, thanks for hosting me.
My first question is very simply, what brought you, what triggered your interest in this question of immunity for COVID-19?
Thank you. I had worked actually on for 2 years. I've consulted with an amazing company here in France that has developed two anti-cancer therapeutic vaccines, and I've been supporting them on a number of issues. So I had delved into immunology, DNA vaccines a few 2-3 years ago, as well as immune checkpoints blockade. So I was sort of conversational in immunology and in cancer immunology. And therefore, I saw a number of red flags as this pandemic started. The first red flag was actually it all started when I realized that I had, with my family, had COVID in early January 2020, and when I realized that, it was probably end of March 2020. And then, as a consultant, I've been trained to go after red flags, to go after things that weak signals, and one of the first weak signal that I had was if I had it in January, and I'm not a 20-year-old, unfortunately. If I had it in January, it meant that many people should have had it in Paris. So I started with that hypothesis, and with that hypothesis, I started modelizing the pandemic. There's another red flag, which was epidemics don't start in care homes. They start with active people, traveling people, schools, but they don't start in care homes. Actually, they end in care homes. And that was the second signal. It didn't make sense to me. So I started to look into the speed and the lethality, and we knew it was running. So I said, hold on a second. I was convinced at the time that it was killing, people were saying 5%. So I told my family to watch out, like everybody else. Everybody was scared at the beginning, but those red flags didn't make sense to me. And then basically I realized that it couldn't be a pandemic that was running fast and was killing a lot. It had to be either running fast and not killing a lot, or running very slowly and killing a lot. And that's when I started looking into asymptomatics. At the time we were talking, the Chinese had talked about a ghost pandemic, and then there was this very interesting report from the French Navy on the Charles de Gaulle, and basically what that said, along with the same one from in the U.S. with the Delano Roosevelt aircraft carrier. What that said was very interesting, because they had spotted about 50 sailors who were mostly asymptomatic, and they sailed back to Toulon. And when they did the report, they realized that they had almost 1,100 sailors who were infected. So it got me thinking, we're talking about the elite of the elite in Navy. They're specialized in threat analysis and detection. They had special medical facilities on board. They knew about the COVID, and nevertheless, they didn't see it. They didn't see 95% or even more than that. Actually, for every one they saw, there's 20 they didn't see. And so that told me that asymptomatic was a very important issue. And since I had worked in biotech and immunology, for me, the main hypothesis had to be that they were immunized. There's, it cannot be otherwise, and it all started from there.
Can you expand a little bit about the Charles de Gaulle, which is an aircraft carrier? What occurred on that ship, as you wrote an article specifically about it?
Well, I basically, I'm not going to take credit for the work of others. It's really the French Navy did an amazing job going into the details and interviewing everybody. I think what was really interesting to me was that for the first time we were seeing that some sailors who are fit and healthy and young, actually 50% of them were supposed to be asymptomatic in the end when they looked into the detail. And that was sort of contrary to what we were seeing in the main, on land. On land, there was the first study in New York of pregnant women giving birth who were being tested during the week of week 3, week 4 of March 2020, and they were 88% of those women were asymptomatics, and so for me, I was trying to figure out why were these sailors who were also very fit, why weren't they asymptomatics? And I started pushing hypotheses. One hypothesis was that, of course, dose had to be important. I know from cancer that your immune system is what I call capacitary. It has a capacity to deal with a certain level of threat or a certain number of tumors. You produce a number of T cells, and that number of T cells is going to destroy a number of tumors. And if it's overwhelmed, then you're in trouble. Well, here I think that's what was happening. The same thing is there's a threshold, and that's what I wrote in that article a year ago. There's a threshold of dose. And I think it's really important to realize that the dose you're getting can be very different, and you might be immune and still get sick because somebody's actually poisoned you with a high dose. And the high dose can come in two ways. Either from somebody who's extremely sick, like an extremely old person who's immune depleted, or it can come, in the case of the Charles de Gaulle, because you're sleeping in a quarter with 20 other men who all have a light COVID, and therefore you're breathing 20x what you should be breathing in terms of virus doses.
And are there any kind of parallels with the Princess Diamond cruise ship?
Of course, it's if actually there's a parallel for lockdown too. Whenever you're locking down people in an environment where the air is not circulating and you have people producing viruses, you're going to share that virus. So immediately, the more people you have inside, the more you interact with these people, the higher your probability of getting infected. And actually, I believe that's what's happening every winter. When you think about it, winter, the seasonality of viral infections is not related to the cold. It's related to, with the cold, we close our windows and we live inside, and we don't ventilate because we want to save our heating systems, or we want to be cold, so we don't ventilate. But if you start ventilating in the winter, and if you start doing that on a regular basis, people might not be getting any infections because the probability of meeting the virus just drops considerably.
And you wrote an article about the situation in New York in May 2020. Can you summarize essentially your findings at the time?
Okay, well, I went to New York because the US were sharing data. much better way than in France, unfortunately. It all started with the IFR, and the infection rate, the lethality rate. Sorry, I was puzzled at the numbers I was hearing. It didn't make sense, right? If you looked at the numbers, you had in Singapore they had 0.05% case fatality rate. In France, we were like 15%. Okay, so it was chaos. And I had read, I don't remember which book, I had read a math book about finding a trend into chaos. So what I did at the time was like, I went back to my benchmarking exercise and tried to normalize for precision, find a proxy for, who was right and who was wrong. And what I did was I said, okay, hold on a second, some people, the more you would have tested outside of each death or around each death, it's probable that you would be more precise, right? So what I did is I normalized the number of tests by death, and then I plotted that versus the death rates. And what I found was a curve that was tending towards 0.1%. So, that was very interesting. And with a very high, by the way, with a really high R-square, I think it was a 78% R-square, which was pretty good, given the mess that was in at the time. So I said, okay, so it looks like this 0.1% fatality rate seemed to be, to make sense. It also made sense with what the gut feel of a lot of doctors was at the time, which was it's like the flu, except it was completely against the narrative. But so then I started to look into other people who were finding similar stuff, and I decided to try to model New York and say, okay, well, what happens if I model New York? Can this 0.1% fertility rate match New York? And the way I did it is I did a bottom up and a top down modelization. The bottom up was basically I went online, and there was this great site that's called kinza.org, and they're basically thermometers by district that give you a sanitized number of people having fever. And these people, so it's very interesting because they give you an expected fever level of, say 1%, and then they give you the reality, and they say, well, something's wrong here. We have an epidemic going on. If you looked at that data in September, in March, the week of March 16th in New York, you would find, I think, something like 5% of people having fever. And it should have been something like 1%. That meant that at least 4% of these people, you could do a leap of faith and say, okay, well, these 4% are probably having fever because of COVID. So that's the only assumption I took is that these people actually had fever because of COVID. But if only 1 out of 7 were symptomatic, then it meant that almost 30% of New York was infected during that week. And then basically I rebuilt a curve, basically the curve that you see in terms of death and in terms of cases. I sort of rebuilt that around it. And at May 10th, I cut the thing and basically calculated if I have all these cases and multiplied by 0.1%, is that going to be close or really far away from the deaths in New York? And I found that it was, I think, if I recall, something like 15,100, which was 100 away from the actual number. So that meant that New York had peaked at the time. But before publishing, I decided I needed a few backups. So I checked the math with a university professor who said, yeah, you took all the conservative elements of it. So I took a lower element. And then I called up Professor Michael Leavitt, who's a Nobel Prize from Stanford. And I sent him an email and I said, Michael, we don't know each other, but I'm getting the same conclusion on New York as you are getting. He was i.e., it's peaking and it's going to be over. He had done it with a different technique, which was basically negative second derivative. So basically, when you're seeing that it's actually starting to tip over, and so I told him, I said, I think New York has been touched 83%. Do you think it's reasonable? And he said, yeah, sure, it's reasonable. It's in line with what I'm saying. So that's what we did on New York. I just published on Twitter. You asked me, whether I was right or not. Yeah, I think New York hit herd immunity last year in May. Last year in May.
So, as you know, there was a kind of a second wave in New York. Wasn't there a second wave? But there was an increase in cases end of 2020, early 2021. How do you explain?
Well, there's 2 points I want to make. First of all, there's certainly not a wave. If you look at the probable New York authority, what they're saying is the maximum number of deaths per day during that time is 4. The first wave was 200. So it's certainly not a wave, or at least it's not the same type of wave. Okay. Now, the other thing that people need to understand is herd immunity doesn't guarantee that people are going to stop dying. It just means that the dynamics of an epidemic are going to start over. That's not possible. So indeed, what I had told at the time, people had questioned me, and at the time I was telling them, well, if somebody flies in and he's very sick or he's sick and comes and see his or her grandmother, there's a first chance they can contaminate her, and that's an issue. But it's not the same thing as what happened most likely in early March, or actually most likely in February of 2020 in New York, where there's been, the virus was probably all over the place.
So your most recent article is entitled Natural Immunity versus COVID-19 Vaccine-Induced Immunity. What brought you to write it?
I guess frustration. There's 2 frustrations. The first frustration is actually it's on vaccinating children, but I'm not going to talk too much about that. That's the thing I'm appalled at, to be honest with you. No, I think what I've been, it was very clear to me that there's a number of things that were wrong or that were being said by many people. Okay, and I don't want to go into the reasons why they're saying some wrong people, either because they're taught wrong or think wrong, whatever, or dishonest. I don't want to go into the detail of it. The thing I know from the work I've done, I have had the opportunity of doing with some very talented biologists here in France, is a number of things. The first thing is that natural immunity is very, very strong, and it was very clear from the very beginning that actually cross immunity was very strong, and we can talk about that. But the thing I wanted to address was a number of fallacies. Notably, if you've had COVID, get a vaccines, right? Because there's the first fallacy was immunity drops right after it. It doesn't make sense in any whichever way you take it. It makes no sense, right? Humanity would have died a long time ago if we would be so fragile that our immunity just lasts a week. Because you need to realize that when there's a pandemic, it lasts a certain time. If ever you catch it at the very beginning and you're not immune for the end of it, that doesn't make sense. You would keep having waves. You'd be talking all the time, and everybody would be very sick all the time. It doesn't make any sense from an evolutionary standpoint. It makes no sense. From a homeostatic standpoint, i.e., your body standpoint, doesn't make sense either. It's obvious that we've all had fever. Okay, we can't be on a level of fever. We can't be at in French. I never know Fahrenheit. I'm sorry, but you can't have 39-degree fever forever, right? That's not your normal state. So you have a peak. The fever is there to kill as much, to help the immune system kill as much virus as it can, okay? And then it drops back. And that's the same thing for antibodies and the same thing for T cells. Actually, T cells, it's very well known that after, after an epidemic, an infection, you don't want T cells or you don't want antibodies circulating around, because they're going to start binding in places that are dangerous, right? Starting doing autoimmune and you don't want to be doing that. So that was my first rationale. I really wanted to tell people that and demonstrate, because I'm a scientist in the sense of I apply the scientific methodology, but I'm not a biologist. I've read thousands of articles, but I'm not a biologist. But I do know that you don't lose your immunity, right? It's been proven. You can read about 90-year-old people who caught who had the Spanish flu and who still had T cells and some 90 years later. Okay, and we've known for SARS-1 also that it remains. And actually, when you look at this whole idea of cross immunity, that's exactly what it is. It's actually not even for the actual disease. It's not for SARS-CoV-2, but for another SARS cousin coronavirus helps you, even if you had it 10 years ago, still helps you today. So the whole waning immunity thing is completely debunked. Thank God, right? Thank God it's completely debunked. So I mean, I can go on. I don't want to be.
Well, I think it's interesting to go through the so-called fallacies you identified, and so you just mentioned one. Let's talk about reinfection, the reinfection fallacy you mentioned.
Okay, so I think for some reason people don't understand how the immune system works, and so the immune system needs a trigger, and that trigger is infection. Okay, now the infection can go on or be cut down immediately, but you still need to have infection for the immune system to start. Otherwise, it's just it's not really immunity. So the fact that reinfection occurs, it's obvious, and also I think in our mind we have a view that we get infected once. No, we don't get infected once. We get infected all the time. If everybody has it, right? If everybody has it, in some countries, the countries are so dense. Imagine in the tube in Tokyo in the morning, if you have somebody who has it, I'm pretty sure everybody's getting it. So the thing is, it's not a discrete. I think it's a mistake to think of infection as a discrete event. It's actually a continuous event, right? But at one point, you get more virus coming in, or you're tired, or for other reasons, and then it becomes symptomatic, right? So obviously reinfection occurs even though you're immune, and actually if you can be immune if you get a big dose, because somebody's very sick close to you, you can actually get a very big fever. But it's true that the clinical data that's coming out is that very few people get symptomatic reinfection. Okay, that's obvious.
Actually, on that particular point, you may want to comment on the studies. There is one from Israel, one Cleveland study about reinfections. What are the key findings?
Okay, so there's one study which is a clinical study from Israel, very interesting one, where basically I think they were. I don't know. Sorry, I'm getting confused with. There's so many studies. So you want to talk about the reinfection or the fact that it's better?
Well, there is measurement of reinfection in the Cleveland study. Maybe you're more familiar with that one, but
Yeah, I'm familiar with it. I mean, it's very low. There's very limited reinfections, and at least in terms of zero conversion, you could see that the resident T cells, once you're immune, you have resident memory T cells in the upper respiratory tract, and basically kills off. It actually kills off the infection immediately. It aborts completely the infection immediately.
Okay. So the third fallacy you identified is the variant fallacy. Can you comment?
Yes, I mean I have this this analogy. I think language is an interesting analogy. I have this language analogy. If you look at the proteome of this virus, it's about 11,000 amino acids, and it seems that it's actually varying 0.2% per year or something like that. We're about it's mutated about 0.3%. Now, this idea that a tiny element would just break up our immunity, in my view, is a huge fallacy. It's completely ludicrous. Right? It's like saying, it's what I'm saying. It's like saying an American goes to London, right? And there's 200 different names that are different between the English and American English, right? And therefore, it would mean that the Americans get there and it's like Germany, and it's not. You can still talk. And the immunity arsenal is very deep and very wide, right? And therefore, it was very obvious to me that the variance is not an issue. You might have, if we can talk about it on the vaccine on the 5%, maybe there can be some issue. But if you have natural immunity, no way. And by the way, it wouldn't make sense, if cross immunity works with 50% or 60% of the proteome in common, of course, with 99.7% in common, you're immune. There's no question.
That brings the question of this fallacy that you call vaccine better than natural immunity fallacy. Can you again comment on that particular one?
Well, that's a tough one. That's a tough one because there's a lot of people who are bending reality, probably for all sorts of good reasons. Well, the first thing is we need to recognize that vaccines are here to mimic a real infection, right? So first of all, to mimic better than nature with a vaccine technology that's very recent would be extraordinary. To beat hundreds of thousands of years of evolution like that. And again, I'm all for technology. I'm all for drug treatment. I think it's great what they're doing for cancer, etc. But thinking that it's actually better than the real thing is a fallacy from an evolutionary standpoint. That's the first point. The second point, from a technical standpoint, you need to understand that again, it makes a lot of sense. We don't get infected in the muscles. Okay, the immune system has developed itself in the areas where we get most infected, right? Where we cut ourselves or where the viruses penetrate. So you have mucus, we have all of that. It's extremely sophisticated and elaborate. So if you shoot a vaccine into the muscle, you're not going to create a number of things that the natural infection does in the upper respiratory tract. And notably, most likely, what you're not getting is resident memory T cells and B cells in that area. And so it's never going to be, and actually I was reading a few articles about it, and there's a few references in the article. It's fundamental because the immune system is an optimized complex system, right? And it's optimized for resourcing and for effectiveness. And the way you can best stop an infection is by killing it off at the start. And that's why I think we can talk about vaccines. I think the future of vaccines, at least for coronaviruses, should be in some form of oral form into aerosols form in the nose to create resident memory T cells there, because you need to shut off, close the door to the infection. You can always, the immune system works after also very well, but then it's huge effort for the body to do. You're going to have fever, you're going to be tired, you're going to have joint pain, and it's also T cells are going to destroy part of your body. They're going to destroy cells. That's why you're losing the taste or smell, because nerve cells are being killed off by T cells. Okay, so I don't think I don't think, and actually clinically, as I state in the article, clinically, it's demonstrated that natural immunity is better than the vaccine. Now, vaccines are effective. They work great. We can talk about safety. That's a different story. But I have no doubt as to their capacity to create immune response. They're fantastic technologies to do that. There are some issues in terms of safety that I'm more concerned about, but that's a different story.
That brings us actually to the fallacy number 5, which you call the innocuity fallacy for vaccines.
Well, it's not only vaccines. I think it's also vaccination. I mean, the whole process. I think people forget. I don't know. People forget that it's a medical act. It's a medical intervention. You're getting a shot. You're going to a place. You're meeting people. That in of itself can be hard on elderly. Now on the vaccine, especially the new technologies, mRNA and DNA, I think there's a few news, or a few elements that are new, or at least for me and for most of us. The first news was that the lipid nanoparticles were supposed to stay in the muscle. And of course, because what these vaccines do is they instruct the cell to produce spike proteins. Okay, so you don't want to be doing that in some sensitive area. You don't want to be doing that in the heart. You don't want to be doing that in the brain. And I don't know anybody who would bet their career and say, yeah, it's safe to be producing anything actually in the brain. Okay. Now we know at least from the data that's been released by the Japanese regulatory authorities on what happened on the BioNTech or the Pfizer vaccine, that at least in the mouse models, the LNPs are going in all sorts of places: the liver, the ovaries, the brain, and also the bone marrow. All these places are not really places you would want to be producing spike proteins. So that's the first point. The second point is there's at least a study in 2018 in France on NLPs, on PEG, which is an additive they've put in there that was causing cardiac anaphylaxis. So basically, cardiac arrest at the second shot. Now, I don't know whether it's, it's just something that made me cringe a bit. The other point I think which is really important is the spike. Now there's at least 3 news on the spike. The first news is that it wasn't supposed. I don't think anybody thought that it would behave the same way it does with its as part of the virus, right? And it actually does. So there's a study I quote in there that basically says that as a protein, circulating protein, it actually is binding to the ACE2 receptor, which is very fundamental. So that's the first problem. It wasn't supposed to do that. The second problem was, I don't think people realized that at the time it has a bit of a piece of gene of the staphylococcus, I think, that is extremely inflammatory. Okay, one of the big problems with COVID-19 is that it's the inflammatory aspects. So actually, maybe we could have taken that away. That would have been better from a safety standpoint from the vaccine. In any case, that's being produced, and therefore there's a fair chance, and we're seeing it, that it's creating inflammatory events in the body. And the last point, I think there's the last point. Let me check. The last point, it's toxic. Yeah, and and there's another point is that it actually damages the blood-brain barrier, or it can. Again, it's been shown to. It doesn't mean that it's going to, in all events, it's going to happen. That's not what I'm saying. But it's been shown to cross the brain-blood barrier, okay, and to damage the brain-blood barrier. And the BBB is super important. You don't want to damage it. That's a critical piece of. I don't think it would call it an organ, but it's a filtration mechanism that protects the brain. So these are all elements that should have warned us of the toxicity. Now, again, I'm not against vaccines. All remedies have side effects, right? And this technology is fantastic for cancer. If tomorrow, and I'm touching wood, but tomorrow I have cancer, I'll be happy to find this technology and I'll take the risk. But I don't think that it makes sense to inject this vaccine, for example, to children. They have zero risk. Why would you take any risk? There's no risk, and you don't want to have to take the risk of having some of these clotting events in the brain. I have a friend of mine in Britain that had a transient ischemic attack 8 days exactly after his second shot. So it does. There's a number of red flags that are showing that are scary, and hopefully, as a society, our community, we're not hiding ourselves behind this. And I think the bigger issue is I think people think that there's this fear that COVID-19 is the plague, and it isn't. It's not the plague. I want to talk about a Regeneron study that's amazing, because if you look at it, it's certainly very interesting from what they're doing with antibodies. But they had a huge cohort of placebo, of untreated infected people that were placebo, right? And they were all at-risk people. And out of all these at-risk people, everyone had at least one comorbidity, and they were all over 50. Okay, only 4% ended up in the hospital. They were not treated, and they had comorbidities. So if you consider that these represent about 25% of the US or the European population, it means that about 1% of the population is at risk of getting to the hospital if they're not treated, right? And there was, prior to March 2020 in France and most countries, I'm pretty sure a lot of family doctors prescribed anti-inflammatory and anticoagulants to people when they saw they were building embolism, right? So, but even if we were that, we're talking about a risk, an infection, an IFR, which is max 0.2% at the worst time in the US, and probably 0.06% today. So it's not the plague, and I don't think it's worth taking such a risk for anybody at least below 30 or 40. But that's my personal opinion. Then at least for children, out of the question. After that, everybody's got their own. They can do whatever they want. It's their life. So I think we have informed consent is the important thing.
Yes. One aspect I would like to comment on, and I think which has not been well explained, is the following. When you have a disease and the focus of my work over the past year has been early outpatient treatment for COVID-19. When you do a treatment early in the disease, you treat somebody who is sick. When you give a vaccine, you give that to healthy people. So the threshold of risk in terms of the principle of not doing harm should be completely different. And because that is the question. We are potentially doing harm to people for a disease they may get, maybe not. And some of these people, including children, are at extremely low risk. But there is a huge distinction between a medical intervention on healthy people versus a medical intervention on people who are sick. And for those who are not familiar with COVEXID and also this room, we are really putting a lot of focus on all these medical intervention on people who are sick with COVID, but when it is treated early, then the likelihood of severe disease, of hospitalization, of long COVID, and this declines dramatically. And so all of these things have to be put in context. And that brings me to ask you the question, which is, what is your take about that CDC guideline, which is not unique in the world at all, which is it's a similar approach in Canada, it's a similar approach in most of Europe, to vaccinate people who have had COVID, who have recovered from COVID. What is your take on that recommendation?
Well, I'm a consistent type of guy. So you heard me. So of course you shouldn't get the vaccine. There's no reason. There's no benefit. If you were if you're unlucky enough to get the COVID, and hopefully it wasn't too bad, you're immune. Why take an extra risk? Actually, I think I'm a data guy. So I went to read a few various events. Actually, quite a few. It's scary. It's very scary. Actually, in some cases, they're writing that they actually injected the vaccine to people who had just had COVID 7 days before, which is crazy because they're still inflamed. So you're just throwing oil on the on the fire. So there's absolutely no reason, and I don't know. Frankly, I don't know why it's never been done before. I think any doctor 5 years ago, or even 2 years ago, you would ask the doctor, say, if you've caught a disease or a virus, do you need to vaccinate against it? They would say, well, are you crazy or what? Doesn't make sense. There's no reason.
As you know, Israel is among the jurisdictions with the highest level of vaccination in the world for COVID-19. But at the same time, my understanding is that they did not vaccinate people having recovered from COVID. Do you have any information on this?
Yeah, I think that's the case. I mean, I don't have the details, but that's what I heard. Yeah, it makes sense.
And how to do it practically? Is it with tests, antibody tests, or proof of a past infection? What is the way to reliably doing it?
I mean, I presume that's not my forte, but I presume you can do antibody tests. That's relatively easy to do. Yeah, sure. You would do antibody tests, and that should work.
Before turning to the Q&A, because we have people who have been very patient, do you have any further comment you want to make at this point?
Yeah, there's a few comments. I think the first one is you were asking me why I continue to that. The one is I was seeing so many of my friends who had fear, and it was for me, it was really touching, and I hated it. I've been working a lot, to tell you the truth, just for that, because I can't stand having kids and having family and friends in fear of something that's actually we're not supposed to be fearful of it. So that's the first point. The second point is I think we're also losing our grip on a number of things. For example, in France, the authorities told people to take Tylenol, or the equivalent of Tylenol, right, in a systematic way. I think you can take Tylenol or in French Doliprane it's called, if ever you have very high fever to cool it off. But if you systematically take Tylenol, what it's going to do, it's going to stop the fever. And the fever, again, is an evolutionary mechanism to help your body get rid of this virus. So whenever you stop it from doing it, what you're doing is you're making the pandemic worse, right? I have an old friend who had COVID in October, and they actually gave him Tylenol. He had fever. He had light fever, but very light fever for 6 or 7 days. My daughter had fever when she had it. She had it for a night, and that was done, over, killed. So I think we need to go back to some of the basics, and also trust our bodies. I mean, of course, and we need to focus on the people who are most at risk. I think that's what PANDA is trying to do. I've been saying all along. And the people who are most at risk are not most at risk because they have problem identifying the markers. Actually, most of them have, if you're 85 years old, I could tell you your immune system is very rich in terms of its span of markers. It knows what to do. Actually, when the immune system starts unleashing, it unleashes. It kills them. The problem is the delay. The problem is in the delay. They have, and there's a fantastic study by Professor Iwasaki in Yale, where she and her team demonstrated that severe COVID patient had 25 to 50% of the dendritic cells of normal patients. And that means that at least that's my understanding, that would mean that the signal, the immune signal that there is an infection going on, would be slowed down by a factor of 8 to 64. That's tremendous. And so during that time lag, well, the virus penetrates. The virus gets to places it doesn't get to when it's just knocked off immediately. And that's in my view, that's the real problem. And that's the problem we should be addressing. We should be addressing the people who are suffering from that, helping them, and the whole idea about antiviral is in a prophylactic way is a potential solution if it works, or if it, and I think it does, but from what I read, but I think there's some people saying it doesn't, or figuring out vaccines that actually prevent that delay, or bypass that delay. If you would do that, then notably this vaccine, an aerosol vaccine, that would solve the problem for real. Because right now the vaccine, at least from what I've seen in the UK, if you have 30% of the over 80 who are not responders, If they're not responding to the vaccine, then they're in the same situation. It's like it's useless. And that's what I said in my previous article, the article I wrote with Mike Eden. At the end is, let's not be overconfident in the vaccine, because some of the elderly are possibly over the edge in terms of their immune depletion, and I've seen it in cancer. If you're immune depleted, vaccines don't work, just simply.
Thank you so much, Marc. Thank you so much.